Welcome to this podcast series, which is brought to you by the Young Epilepsy section of the British branch of the International League Against Epilepsy.
Hello everyone, and welcome to another podcast organized by the Young Epilepsy section of the ILA British Board. My name is Maria Gogu, and I'm a pediatric neurologist from Greater Ormond Street Hospital for Children in London. Today, I'm together with Dr. Sana Hanna, a lecturer in neuroscience in Lancaster University. Hello, Sana.
Hi, nice to meet you.
Nice to meet you too. Our topic today is focused on the relationship between sleep and epilepsy, and we will try to touch some very special aspects of this relationship. And for this reason, we have a very special guest with us, Dr. Samantha Chan. Samantha is a consultant pediatric neurologist at St. George's Hospital in London and also a lecturer at UCL Institute of Child Health. Welcome, Samantha. Thank you for being here.
Hi, thank you for having me.
And I have to say that Samantha is also a good friend, so I'm really excited for this podcast today. Samantha, the first question that comes to my mind is what brought you to this field of research? Which aspect of sleep did attract you?
So it really was a chain of events. So interestingly, starting from some negative results and maybe a bit of serendipity and just people that I met along the way. So the story starts when really I did my PhD with Professor Helen Cross at the UCL Great Ormond Street Institute of Child Health, and a major research theme for her group is comorbidities in childhood epilepsy. So in terms of the psychological, psychiatric and cognitive burdens, which often have more of a bearing on quality of life than other key outcomes in seizures themselves. So for my PhD, I examined a phenomenon called sleep-related memory consolidation. So I guess the easiest way to think of that is that in general, people remember better after a period containing sleep, especially deep sleep, than after a similar length period of wake. And this phenomenon's now been studied in sort of various conditions in adults and children, including things like ADHD and so on. And the mechanism is linked to sort of slow oscillations, and there's data from rodent models talking about place cells replaying the sequence of firing in sleep and so on. So the hypothesis was that this might be impaired in the children with epilepsy, but contrary to our hypothesis, I found that this was intact in children with focal lesional epilepsies. And I also found, examining their EEGs, that really sleep architecture was generally quite well preserved, despite sort of parents reporting really across the board that their sleep was severely disrupted. And it was in the process of examining slow sleep that I became interested in the concept of sleep homeostasis. And this homeostasis operates at two levels, really. So the first kind of larger scale level, which we're sort of all familiar with, is that when we're sleep deprived, we then sleep for longer and more deeply when we're given the opportunity for recovery sleep. And then at the neuronal level, there's a synaptic homeostasis. So this you can sort of see in the EEG amplitudes across the course of the night. And so over the course of the night, there's a downregulation of synaptic strength overall in the cortex. And this is theorized and also supported by experimental evidence to happen over the course of slow wave sleep and to support learning and memory. And so this concept is quite tantalizing in the field of epilepsy, because we know really well that sleep deprivation is a common trigger for seizures, but also that cortical excitability is decreased with synaptic downscaling. So it's just, it just raises the question, well, what are the implications? I don't know, I'm going on a little bit now. So this connects with the paper we'll talk about a little bit later. I don't know if you want to go into this now or we'll come back to it maybe. But that's how I got interested in sleep and sleep homeostasis and its relationship to epilepsy.
Okay, thank you, Samantha. And can you explain to us the overall relationship between sleep and epilepsy? Because it seems to be quite a complex relationship.
Yeah, so that could almost be a whole podcast in itself, couldn't it? So, I mean, I guess just very briefly, I mean, the link between sleep and epilepsy has really been known about since ancient times. So there is this sort of treatise by Aristotle, dated around 350 BC, called On Sleep and Sleeplessness. And so in this, he describes not only nocturnal seizures arising from sleep, but for me as a pediatric neurologist, what's interesting is that he also observed that infants have a greater propensity to both sleep and epilepsy, which I thought was that's just quite a good observation. And so in terms of understanding the connection, I almost feel that we haven't made that much progress over the centuries, or rather millennia, since then. I think maybe the key things are so there's increased synchrony between neurons, perhaps, in both. You can see some morphological similarities between sleep slow waves and spike waves. There's some evidence from both in vitro and animal studies that the former, under some circumstances, can transform into the latter. There's so much to say, really. I mean, clinically, obviously, both sleep deprivation and sleep onset are used to provoke seizures to capture them on EEG.
Would you say that sleep problems are quite common in the epilepsy population as a whole?
I think that, well, the short answer is yes. I think in terms of my clinical and research experience, so it's always been talking to families, and I think really across the board, they'll all tell you that that sleep is disrupted. I think a lot of this is sort of behavioral sleep disruption, behavioral insomnia. There's a lot of anxiety around, is the child going to have a seizure overnight? Sort of parental co-sleeping with the child is quite common. I guess one thing to say, so I did have a healthy control group, and I think what's interesting is to take this into context of sleep in healthy children, because if you ask parents of children with no other health problems, I think roughly a third of parents would say that their children don't sleep well. It's almost kind of sometimes you're rating parental dissatisfaction in a way. But I think if for the older children, when you can ask them that directly, I think sleep is commonly impacted in people with epilepsy, whether or not they have nocturnal seizures.
Mm-hmm. And would you say that sleep problems tend to be under-recognized in patients with epilepsy?
I don't know. I guess it depends on by whom. I mean, I think in the pediatric group, parents are very, very aware of sort of whether their children are sleeping well or not. So as I say, and even the sort of overcalling the problems in healthy children. And I think, particularly with anxiety around those with nocturnal seizures, maybe under recognition in the clinic. So the question is, well, if you're a clinician, you kind of need to ask yourself, well, how often do you ask in clinic, or do you ask in clinic as a routine? So how, does he or does she sleep well at night? Or to take a sleep history and talk about sort of wake and sleep times, and really just to compare that to what is appropriate or expected for age, to sort of elicit the sleep problems.
Mm-hmm. And are there any specific seizure types or types of epilepsy that are related to sleep?
I think epilepsy is, along with many other disorders, actually, even ones that are not primarily neurological, have a sort of circadian pattern to them. So I think conventional wisdom, about temporal and frontal seizures and the sort of diurnal preponderance of certain times of day, such as the autosomal dominant nocturnal frontal lobe seizures. But in the child group, I guess famously the Paniotopoulos and Rolandic epilepsies. have to apologize for using the eponyms, but I think it's sort of for clinicians, it just evokes that picture, the child coming into their parents in the middle of the night, unable to speak, or the child with the pronounced autonomic symptoms, And these sort of falling under the bigger category of things that go bump in the night is why they've come to the pediatric clinic. So yes, certainly there are sleep-related epilepsies.
And Samantha, I noticed the word sleep homeostasis that you mentioned, and this brings to my mind your latest study about the effect of epilepsy on sleep homeostasis, which was actually also awarded by the Developmental Medicine and Child Neurology Journal. So I would be really keen to know what was the journey behind this study and how did you decide to look at this aspect? And I think it was a collaboration between UCL and Children's Hospital in Zurich. Is this correct?
Yes, that's right. So I alluded to this slightly earlier. So having found that the children with epilepsy, or at least the group I looked at, who mainly had focal lesional epilepsies, seemed to have improvements in memory consolidation with slow wave sleep, and actually superficially, so just on visual analysis, the sleep architecture tended to be fairly intact. I wanted to take the data analysis a little bit further. So I wanted to return to my data and really to look at sleep homeostasis as reflected in the slow wave activity. So the group of Reto Huber at the Children's Hospital Zurich, they're a major group in pediatric sleep research, and a lot of their work involves high density EEG in various groups, so both healthy children. So they've described the evolution of slow wave activity in healthy children from infancy through to adolescence. They talk about the sort of topological distribution of the slow wave activity and how it evolves. And so they've got this really good sort of setup describing how things evolve with time, and they've looked also at sort of focal aspects of it as well. And so I really wanted to go back to my data and work with this group to look at sleep homeostasis in my patients, and to try and correlate this with the cognitive and the clinical measures that I already had. And I also had age-matched healthy controls as well. So I really wanted to see to really delve a little bit more deeply into what are the differences here and what can they tell us. Do you want me to outline the story, a little bit of the study? So I think part of it also, great. Yeah, it was a little bit of, I guess, a bit of a coincidence that Bino Bolsteli, who's a pediatric neurologist in Zurich, came over to visit also, and so we were able to work together to look at the data. So I guess what I did find again, so and correlating with this intact memory consolidation, was that the slow wave activity declined. So this is the measure of the sleep homeostasis across the night. So this thing where I mentioned when you're sleep deprived and when you look at the EEG visually, it's got lots of slow wave sleep and the amplitudes are high, and then by the end of the night you have your lower amplitude waves, and you've got, if you've had sort of more sleep deprivation, there might be longer periods of slow wave activity. So this sort of exponential fall in the slow wave activity overnight I saw in my patients as well as in the controls, and that was intact. But what was quite interesting was that the early night slow wave activity, so which you would expect to reflect the activity during the day, was lower in the patients than in the age-matched controls. This was a bit of an odd thing, and I almost felt, well, if this is a sort of artifact of the conditions of the study, you'd almost expect it to be the other way around, because if the patients had maybe not slept so well in hospital or been sleep deprived or something like that, you'd be expecting higher slow wave activity, or even if it was some kind of dysmaturity, that it would be higher. So this was almost contrary to what we expected. And then looking at what this related to, it seemed that the ones who then went on to have seizures later on in their admission, so I had a sort of 4 nights continuous recordings, seemed to have more of a deficit in the early night slow wave activity than the controls. So this was almost this is slightly serendipitous one. I wasn't really expecting it, and that's really led on to the further work that I'm doing now.
And Samantha, I'm just listening. Oh, I'm sorry, Sana.
That's okay. You go ahead.
I'm just listening to what you're saying, and I'm thinking if the opposite would be something to imagine for future, if we could modify sleep in order to improve epilepsy control and seizure outcomes.
Yeah, so this was one of the lines of inquiry that arose from these results. There was a question of, well, can you boost the amount of slow wave activity? And the various modalities have been used in an experimental setting. So it's actually a couple of decades now. People have used things like transcranial direct current stimulation, so in a certain phase-locked manner to increase the amplitude of individual slow waves, and then sort of evaluate performance on this sleep-related memory consolidation of various tasks in the morning. So this has been done in small groups of adult volunteers, but it's not a very nice modality, and there are sort of more non-invasive ways to do this. The Zurich group have investigated using closed-loop auditory stimulation. So this is where a sort of sub-threshold sound is played during slow wave sleep. So not loud enough to wake the person up, but enough of a sound stimulus to boost the amplitude of the slow wave, and to increase the length of the slow wave train, and try and again relate this to the cognitive measures on certain memory tasks tested the next day.
Okay, that's very interesting. What kinds of sounds are they using?
So it's a pulse of sound, and so it's described as pink noise. So I think we all know about white noise. And so this is a whole sort of other field of acoustics, and not really my current work. But there are various other colors of noise. So there's brown and pink. So pink is not quite as white, so it's got a bias towards lower frequencies. So if you think of kind of running water, and more calming sounds, and the theory is that it's less likely to wake you up.
Okay, yeah, it's very interesting because I was actually using a different frequency, just a single, like 1 kilohertz pulse to wake people up, essentially, or to induce sleep arousals. So I find it very interesting how different sounds can have different influences on brain activity and your tendency to wake up. So can you tell us a bit more about your current research direction?
Yes, so this is another sort of meeting. So I was introduced by a mutual friend to a mathematician. So he is Professor Mark Goodfellow, who's a mathematician at the University of Exeter, and his work is on neural mass models. So essentially, I suppose for the non-mathematician, a big equation with lots of parameters, which all correlate to actual sort of things, neurophysiological parameters that have an experimental basis. So things like sort of sodium conductance and ampere-current, things like that. Representing the activity of groups of neurons. So there's inhibitory neurons and excitatory neurons. And by manipulating the parameters, you can essentially create some simulated EEG data, so both in the time domain, which is what we're used to seeing when we look at the squiggly lines from recorded data from patients, but also in the frequency domain, so when we're doing like a fast Fourier transform, for instance. And so we've used my sleep EEG data to build models, and by changing the parameters, you can bring the model sort of closer or further away from seizure space. And on the retrospective data, we found that the patients who go on to have seizures further, so up to 4 days down the line, we can see differences in the neural mass model that's derived from their sleep EEG data.
Okay, very, very interesting. So what kind of data was used to make these models? So you mentioned it was sleep EEG data. So are these like continuous recordings across the night?
Yes, so the recordings are continuous, so you don't need a very long recording to make the model. It's really just a snippet. But the strength of it being a continuous recording is then we do know which patients went on to have the seizures later. And of course, this is all retrospective, so the next step will be to test this in a prospective study to make a prediction using a model. The patient has some kind of intervention, and then see whether the predictions of the model correlate at all to the patient-reported outcome.
Okay, yeah, very interesting. That was actually my next question about the prospective studies. So where do you see this going potentially in 5-10 years' time in terms of real-world applications for patients who suffer with epilepsy and sleep disorders, or one of the two?
Yeah, I mean, I think the study of sleep in patients with epilepsy has really a lot to contribute to the field. We all know that there is a link, which is how we started our discussion in the beginning. So, this is utilized clinically in terms of we perturb this system by sleep depriving patients or doing a recording when they've been allowed to have their recovery sleep. So what information is there in that sleep EEG that we can extract and use for prediction or to help with decision making? There's almost a kind of parallel with oncology research where they might take some cells from biopsy, say, and the patient then has a personalized sort of in vivo or in vitro model on which multiple medications can be tested. So my hope is that using the sleep EEG data, we can derive a personalized in silico model, if you like, on which interventions can be tested. So, for instance, if there's a medication where we know the mechanism of action, so for example, perampanel, and then you can manipulate parameters that change the AMPA current, saying, okay, well, this is going to bring the patient further away from the seizure space, or even connecting back with the other line of inquiry, which is how to manipulate the slow wave activity. Well, how are you going to decide what sort of protocol of stimulation is best? And so, maybe building on this to make something, I guess it's still parsimonious, but sort of sophisticated enough where you could apply a simulated stimulation, if you like.
Mm-hmm.
And it would work even with, say, other modalities that are coming in, such as DBS or things like that for epilepsy, where you don't have to test it on the patient because you have this almost like a avatar or a digital twin to test it on their behalf.
That sounds really exciting. So yeah, I think that seems to be the way the field of medicine as a whole is moving, the personalized medicine. So yeah, I think particularly for epilepsy, where it's such a kind of almost a case by case disease. I think there's a lot of potential there. In terms of balancing your clinical work with the research, how has that been for you? Have there been challenges in terms of finding support for your research, finding the time for your research, and finding funding?
Yeah, I think challenging is almost a bit of an understatement. I guess it kind of cuts both ways. I think having been a consultant now for just under 2 years, I think a lot of the the dilemmas I've had sitting in clinic, you have this complex patient who's already on 2 medications, and there essentially is no evidence base on which to choose what is a good third medication to add, or what you should swap in or swap out, and that's informed the direction of my research. So just to start with the positives. In terms of challenges, I guess what might be particularly relevant to audiences who are sort of in the early career stage, particularly clinicians, is there's the kind of jump between trainee and consultant. So when you finish your clinical training, and then this area of limbo. I mean, this was really, really difficult. I think from the time when I was a medical student, I'd always wanted to be an academic, and I think sometimes the work that's been done to sort of streamline or structure academic pathways hasn't benefited everyone, particularly people who don't enter into an academic pathway at the prescribed times in their clinical training, and that's been very hard because I haven't taken a conventional path.
Yeah, I'm sure that many trainees will be touched by what you have already said, Samantha, about non-conventional paths and how hard it is to balance, between clinical work and academic interests. I have always had the impression that sleep training is quite underrepresented in curriculums for neurologists, and not only adult neurologists, but also pediatric neurologists. What's your opinion about that? And do you think that there is any way to improve things and to increase exposure of neurology trainees to sleep medicine?
Yeah, I think this is a very important topic to address, actually. I think I personally try to insert some teaching about sleep whenever I get invited to speak about anything, really, whether it's to medical students or trainees, or sort of neuroscience MSc people. There isn't a sort of dedicated, so in the UK there is no dedicated sleep medicine training pathway, certainly not pediatric sleep medicine. I think there is some work being done with the Royal College of Child Health and Pediatrics. So they already have this thing called a SPIN for epilepsy. So it's a sort of, you do a little specialist module for the sort of trainees who are later on in their training. And so there will at some point be a sleep medicine one as well, although that's not out yet. I think the other thing is the British Pediatric Neurology Association have a distance learning course, and it would be, this is something I need to maybe raise or suggest, that perhaps, in a course like that, there should be some explicit sort of topic area about sleep. But on the other hand, I guess, sleep and sort of circadian rhythms, it's so pervasive. It's kind of in everything, if you like. It's sort of nowhere and everywhere at the same time. I think anyone who's done any sort of training in epilepsy or neurophysiology is sort of well aware of this sort of the bidirectional relationship between epilepsy and sleep. So I guess it's almost, you almost need to get it more in the general pediatrics, so from a pediatric point of view, in the general pediatric curriculum as part of sort of developmental pediatrics, if you like, because I think so much of understanding the pathophysiology comes from understanding the normal physiology and the normal development with time.
Okay, thank you, Samantha. So I think we'll leave it there for today. So yeah, thank you so much for joining us on behalf of all of us here at the ILAE Yes British chapter. It's really been fascinating to learn about your research. And thank you for listening.
Thank you for having me.